Hi, you are in the ladies' room with Dr. Donica, the only public ladies' room you can enter anytime without ever waiting online. I'm your host, Dr. Donica Moore. We'll be having real conversations with real women about really intimate issues. They may be embarrassing, sad, or funny, but they will always be interesting and informative. You know, like the best conversations you've had in ladies' rooms with your best friends, or total strangers and a physician. Please join us. Hello, and welcome to another exciting episode of In the Ladies' Room with Dr. Donica. And today we have a topic that has affected just about everybody. In fact, just yesterday, I was talking with a dear friend of mine who apologized to me for not listening to all of my podcast episodes, saying that she tries to focus on the topics that are most likely to affect her. So I really hope she's listening to this one, because we're talking about the F word, and that's fibroids. Now, most American women will develop fibroids at some point. In fact, one study found that by age 50, 70% of white women and 80% of African American women had fibroids. In many cases, they don't cause significant symptoms, and many women may be completely unaware that they have them. But many women also are confused about what they actually are. Very simply, they're benign, non-cancerous tumors that grow within the walls of the uterus or the womb. We don't know why. They vary widely in size, location, number, and symptoms, which may include pain, heavy menstrual bleeding, which I refer to as crime scene bleeding, bleeding between periods, and may even be accompanied by infertility, miscarriages, and early onset of labor. There are a wide variety of therapies used to treat women who have symptoms. We're going to talk about many of them, and that may include drugs, surgical removal of individual fibroids called myomectomy, a minimally invasive procedure called uterine artery or uterine fibroid embolization, or the most well-known option, a hysterectomy, which is removal of the uterus altogether. There are more than 200,000 hysterectomies performed each year in the United States. And if I don't have your attention yet, let me tell you that the annual direct healthcare costs are estimated to exceed $2.1 billion. So today we have a super expert. She's known widely by her Twitter handle as the Fibroid Lady. I love that. We're talking to Dr. Theresa Caridi. She's an assistant professor in the Division of Vascular and Interventional Radiology at MedStar Georgetown University Hospital in Washington, D.C. So one of the things I'm going to ask her to talk about is, what is interventional radiology anyway? But a little bit more about her background. After attending the University of Florida for medical school and radiology residency, Dr. Caridi completed her fellowship in vascular and interventional radiology at the University of Pennsylvania before joining the faculty at Georgetown. She's an active member of the Society of Interventional Radiology and is also an officer on their foundation board of directors. She is widely, highly regarded as a preeminent physician in the Washington, D.C., Maryland, Virginia area, and accordingly has been named a Washingtonian top doctor in 2018. In addition to the treatment of uterine fibroids and other uterine conditions, she also has a special interest in pelvic venous congestion, varicocele, prostate hypertrophy, and pulmonary AVMs. I don't think we're going to be able to get to all of those topics, but please join me in welcoming Dr. Caridi. Thank you for joining us in the ladies' room.
Thank you so much for having me. I'm excited, but your intro was so good. I don't know what I'm going to talk about now.
Oh, I have questions.
Yeah.
And actually, my first question is this the most unique, interesting, or different experience you've ever had in a ladies' room? Or do you have another experience you want to share with us?
That's a good one. I actually do have a pretty unique experience, and that has happened in a ladies' room. Has nothing to do with fibroids or not even to do with adults. But I have a 4-year-old who, at the time, I think this happened, she was 3. 2.5 or 3. She was recently potty trained, and she is one of those high anxiety type kids. Like, everything has to be introduced 100 times before she really feels comfortable with it. She would kind of the kid that would stand outside the ball pit and say, "Mommy, I want to go in." I'd say, "Go ahead." And she'd say, No. So we're in the airline club at the airport, and we're about to get on the plane, and I say, "We have to go potty." And so she comes with me, and she's reluctant, and we go in the stall, and I say, "I'll go first." And she asked me, "Is this a better potty or a worse potty?" Meaning, does it flush on its own? And does it startle her, right? And I said, "Oh, it's not such a good potty, but I'll show you. It's not scary. Nothing happened." And so I went, she had a complete panic attack, and
Mm.
she was standing in the corner of the stall saying, no, 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 tears shedding. And I said, finally gave in, and I was like, you know what? You can go in the sink. You can
Right.
go in the sink. It's not scary. I'll hold you over it. We'll, and then we'll clean up and wash our hands and go out. And I said, but we don't talk about this outside the ladies' room. Sure enough, we go outside the ladies' room. We go and meet my husband and my son out in the club lounge. And the very first thing she says, across probably about 20 feet away from my husband, is, "Daddy, Daddy, guess what I just did? Guess what I just did? Mommy let me go potty in the sink." So she announced that to everybody. So no secrets are actually maintained in the ladies' room, in my opinion. But that was probably one of my most unique experiences.
Yeah, and that unique 3-year-old voice that carries.
Yeah, and it was actually like I was a hero. She thought I was just absolutely fantastic for letting her go potty in the sink. I was mortified, but as a mom, you know how it is. You got to do what you got to do sometimes.
Absolutely, but whatever works. There's no right answers, but there's lots of wrong ones.
Yes, exactly.
I will tell you though, I find it very intimidating nowadays in these various high-tech ladies' rooms and frustrating when I can't figure out how to flush the toilet because
Yeah.
it's supposed to be automatic, but they didn't really go. And then there's supposed to be a button, a fail-safe button, and you can't find it. Or worse, you can't figure out how to turn on the water in the sink because you're supposed to be able to wave your hand over it magically, and half the time that doesn't work. So
Over some kind of trough that doesn't look like a sink, and where is it? Yeah, yeah.
Right. That's why it's very important to carry your emergency supply of Purell for when you can't figure out how to make the sink work in an airport bathroom. And I spend way, way too much time in airport bathrooms. But anyway, I guess women who have fibroids spend much more time in the ladies' room too.
Yeah.
So tell us about fibroids, and tell us, first of all, actually, how did you become the fibroid lady?
I have to admit, the fibroid lady title is a bit self-proclaimed, but I did, where I did my interventional radiology training at Penn, one of my mentors was, his work was really in fibroids. And so I got very familiar with the patient population and the procedure. And I knew I was coming to Georgetown at some point in the year when I accepted a faculty position at Georgetown. And one of the world's experts in fibroids, fibroid embolization in particular, and most of the research or a lot of the research that has been done is by my mentor at Georgetown, Jim Spies. So as I kind of developed in my fellowship, knowing where I was going, I really tailored my experience to what I was going to be able to offer and be involved with at Georgetown. And so I became very familiar with that procedure and population. Then I came to Georgetown. I've been there for about 5.5 years. I've learned from the best. And so it's just been a great experience. And, I feel very equipped to treat women, whether they're coming from a gynecologist or not, with this procedure, because I see them all the time. I manage this all the time, and I'm just very comfortable with what needs to be done. Also, I at Penn, I was pretty involved in what we do. These minimally invasive procedures can be done all over the body. And while fibroids are a benign condition, there are some cancerous conditions that we also treat via embolization. And there's a pretty big, established center at Penn where we did a lot of interventional oncology. It's what it's called. So treating these cancerous tumors. So when I came to Georgetown, I kind of was, had an idea of a mixed practice. And, cancer is one of those things that's really, touching, obviously needs some real supporters in that area, physician supporters and physician leaders. So that's kind of where I saw my career going. But it turns out when I started to see these women in clinic that have fibroids, they were just a voice that was very unheard for a very long time. It was a bit of a taboo subject, bit of an unknown subject, not really, many people weren't well educated in it. And so being able to have an impact on their care was really substantial and eye-opening for me. And the way they come back after an embolization procedure or other procedures to treat their fibroids is so impactful. It changes their quality of life completely. I cannot put enough into words how much it means to them to get a treatment, particularly a minimally invasive one, that really takes care of and completely changes their quality of life.
So I want you to walk us through what embolization is and what the treatment involves. But before that, every time I give a lecture, about mentioning minimally invasive procedures for fibroids. And anytime I mention the term interventional radiologist to a lay audience, the question I get 100% of the time, and I do play this little game when I give talks, is trying to predict what the questions are going to be. And generally, I can predict 50% of the questions word for word. 25% are a little bit unusual. And then eventually one person comes up with one question I never heard of before. But the question I get 100% of the time when I say the words interventional radiologist in a talk to women at large is, what is an interventional radiologist? Yeah. So start there.
Well, yes, for sure. I'll tell you a little bit about that, but it brings up a good point. And I think part of the reason why, fibroid embolization, part of the education problem with fibroid embolization is the fact that people don't even know who we are, much less what we do. So interventional radiologists, they are derived from the field of radiology because all of the procedures that we do are image guided. And back when the field first really became prominent, they were really mostly diagnostic radiologists who read images, but then used that imaging knowledge to be able to perform procedures. The reason why we call it minimally invasive, and your point is well taken, most women, when we say minimally invasive, they think of laparoscopic. They think of something that we do with a camera, but we're talking about much smaller than that. We're talking about a pinhole incision, something that doesn't require suture, not glue, not anything. It's just got a kind of a glorified Band-Aid on the spot after we're done. And so that's the degree of minimally invasive we're talking about. And so interventional radiologists perform these minimally invasive procedures, non-surgical procedures, through a pinhole, oftentimes in the leg or the wrist, various other locations. And basically we go and treat something in the body that we can only get to by seeing with imaging on the outside of the body. So the whole time we're operating, for lack of a better word, we're doing so with a sort of like a real-time, roll of x-rays.
The number two question I always get when I talk about this, you would think by now I would learn to just incorporate the answers into the talk, is how does somebody come to find an interventional radiologist? Do you have to be referred by your gynecologist? Do you call up 1-800 the fibroid lady? How do you find a doctor? Are you seeing patients on an outpatient basis? How does that process work for most patients?
Yeah. So a lot of people, as you say, a lot of people aren't familiar with it on an outpatient basis, but most of the hospital, particularly in like a tertiary care center, they use interventional radiology services all day, every day. We place a lot of catheters, tubes, those kinds of things. So people in the hospital are very familiar with it. But what about those outpatients, right? And these more elective type procedures. So we are
Which fibroids are. Fibroids are generally, an overwhelming majority of fibroid procedures are elective.
Yeah, exactly. Absolutely. Other than maybe the ones with absolutely severe life-threatening anemia who are hospitalized. Yes, but you're absolutely right. So yeah, we see patients on an outpatient basis, just like any other physician has a clinic. So on Thursdays, I have a clinic. A lot of my patients are women, but as you mentioned, in some of my other interests, it's across the board and other topics as well. And my colleagues are the same way. None of us in my particular practice, although some practices cross over with some diagnostic imaging as well, none of us in my practice read any kind. We never sit in a dark room reading images. The only way we utilize these images is that, fortunately, we've been board certified in being able to read the images, so we can use it to really plan for these procedures and really optimize what we're going to do at our procedures by being experts at the imaging as well. But yeah, we run a clinic just like a surgeon runs a clinic or anybody else who practices medicine.
And what percentage of your patients would you say find you on their own versus are referred from another physician?
I should probably look at those numbers at some point. I don't know that answer, but I would say that most women come via a gynecologist or another physician, most. But it depends on the procedure. If we're talking about fibroids, I would say most are referred. However, there are definitely, probably I would say a quarter of patients that are self-referred. So it's still a fair amount of patients that come that way. Various other procedures are a little different. And I think actually it's interesting with men's health topics and men's health patients, which I also perform procedures on and see in clinic. Those are a little different. Actually, men tend to ask more for what they want and look and find it on their own. And they haven't really established a relationship to the degree maybe a woman might have with their gynecologist or OB gynecologist. And so oftentimes it's not unusual for them to be self-referred. So it's a little bit different in how they get to me, or how they get to my colleagues. You know, it's in various different ways, and kind of procedure or disease dependent.
Okay, so let's focus on fibroids then.
Okay.
So say somebody has fibroids. Let's just for argument's sake, and say she's a 50-year-old woman. She has multiple large fibroids. They're causing heavy bleeding, and she's nowhere near menopause yet.
Okay.
She goes to her gynecologist for the bleeding. She has a conversation with the gynecologist. The gynecologist diagnoses the fibroids and the problem. And then what happens?
Yeah, that's a good question. So sometimes that gynecologist will refer this woman to see an interventional radiologist to discuss the sort of the option that's not in the gynecologist's wheelhouse, right? Sometimes, and a lot of the time, unfortunately, it's only in the setting where they may not be a good surgical candidate for various reasons. But there are a lot of gynecologists, fortunately, that we work very collaboratively with, not only in my own institution, but around the general area, that we'll send patients to discuss this option with us, even if it might be that their best option is a hysterectomy, just so that they can hear and be part of the shared decision-making and what treatment they ultimately get. We know, and I don't want to get too much into numbers, but we know that of those women who know they have a fibroid diagnosis, only about 44% of them have actually ever heard of uterine artery embolization or uterine fibroid embolization. So we know that the majority of them are actually not getting to us, which is actually been a problem for a long time. But interestingly, it's not really getting better, despite the fact that there are 20 plus years of this procedure being done and having proven efficacy, and a vast amount of research and how it reduces pain, reduces time in which a woman is away from work and her normal life activities, and how it can actually have similar outcomes to surgery.
And far fewer complications.
At least major complications, yes. Yeah.
So we did do a previous podcast episode where we had a woman named Donna Hopkins who actually was in her I think she was 51. And she said she walked to the hospital because she only lived about 10 blocks away for a myomectomy. So a myomectomy is an option that some women choose where they want just the fibroid or fibroids removed and not the uterus, which was a complicated thing in her situation because she wanted to keep her uterus because she still wanted to be able to ultimately have children, but she was already 51. So that was already a complication. But she had major complications of the surgery and wound up losing her leg in the process. Oh my
goodness.
So, very extreme case. The story does have a very happy ending because she wound up becoming a elite Paralympian as a result. So I encourage everybody to listen to that episode. But explain to us what I think is counterintuitive about myomectomies, or removing just the fibroid, is a lot of people think that if you just remove the fibroid, or if you just remove the fibroid, it's a lesser surgery or less likely to be complicated than removing the whole uterus. Explain to us why that's not true.
Yeah, well, it can be. It depends on where the fibroid is located and how big it is, and how many there are. So that's the problem with the myomectomy, is that, I look at hysterectomy and uterine fibroid embolization as global treatments. A myomectomy is really limited in, how much can be removed and sort of where the fibroid is. And, if it's one fibroid and it's relatively small size, that's causing a lot of symptoms, that's a totally different story than multiple big fibroids are in various locations, which makes surgery a little bit more challenging. I think that there is a misunderstanding that if you just go in and remove some fibroids, that it might not have to be open, or it might not have to be through the abdomen. And none of that is really true, unless it happens to be that the fibroid is single and is in the endometrial cavity. So where a baby forms in the womb, that cavity, which connects to the outside world, if the fibroid is only in that location, sometimes a gynecologist can do what's called a hysteroscopic myomectomy and just go in essentially with a camera and go and remove that fibroid. That's a completely different thing than when fibroids are on the inside of the uterus, in the muscle of the uterus, or on the outside surface of the uterus, which in those situations oftentimes definitely requires an abdominal incision, and whether it's laparoscopic or completely open is dependent on the size of the fibroid. So you're right, a lot of times it is not a lesser surgery than actually getting a hysterectomy. And,
So tell
and
us,
particularly cutting into these areas versus just removing the uterus, I would imagine. And although I've been in plenty of these surgeries and watched, I like to, we work collaboratively, and I like to watch when I can and go and join some of my gynecology colleagues in these surgeries. Removing the whole uterus sometimes can be a little bit more simple, I would imagine, than actually having to dissect and take out these fibroids.
right, in large part because of the blood supply. So
Exactly.
that's what we're trying to do, is control the bleeding. But tell us what embolization actually is, first in general, and then specifically with respect to fibroids.
Yeah. So embolization is the idea of taking away blood flow to an area. Most of the time we're talking about a tumor, whether benign or cancerous. And in the situation with fibroids, benign. And what we're doing is basically starving that of its nutrients and oxygen so it can't live. So I kind of liken it to a nice ripe fruit, like a grapefruit, shriveling down.
We always compare tumors to fruit.
Food. I know. Right. It's the spiritual nature,
that.
I guess. I don't know. And the fact that you can kind of think of it as alive and then becoming something that's dead, like a prune. Mm-hmm. And sometimes we don't get that. Depending on the size, we might not get that significant reduction. And typically we get somewhere between 50 and 60% reduction in size with embolization for fibroids specifically. But the point is that we're starving it of its nutrients. It's basically becoming a scar. And, so then it can't have its symptomatic effects that it used to have.
So are you
very
starving
different than
just the fibroid, or are you starving the whole uterus?
Yeah. So that's the nuance of doing a fibroid embolization. And that's why you want to go somewhere where people are experienced and have done this a lot. And really in my mind, to people who are well-trained, like an interventional radiologist, for doing this. And so what it is what you're definitely treating when you treat the uterine artery. So this is very specific to fibroids, I'll say. It's different in other locations in the body, but when you're treating the uterine artery, all these fibroid branches branch off of that. So what you're essentially doing is closing those off with these little things that are almost like a grain of sand. We call them beads, colloquially, but they're embolic material. And so you go in there and you fill those vessels that go to the fibroids. And what you don't want to do is shut down the uterine artery completely. It's very rare to do that, and for it to be significant enough to cause anything detrimental to the female down the road. However, in the immediate post-procedure period, if we really do too much embolization, what we worry most about is the pain related to the procedure. So when we treat the regular myometrium, or the muscle of the uterus, that's what we don't want to treat. And when we do that, we get a fair amount of pain related to the procedure, especially in those first couple of days. And so, we really try to treat and stop the embolization at a point where it treats the fibroids alone.
So how are you getting to how are you getting to these blood vessels?
So
walk me through it from when a patient walks in the door.
Okay, got it. So we see the patient in clinic, we prepare for the procedure. They come back a separate day for the actual procedure, just like any other kind of surgery or procedure. And usually it's very quick, within a week or 2 weeks, if they so desire. They come in, it's in what we call a 23-hour observation procedure or an outpatient procedure. There's a lot of arguments about that. That's a topic probably that we don't want to get too into, but nonetheless, they come in the day of the procedure. They, when we get them on our table, which has imaging over it, so we're able to watch ourselves during this procedure, we enter one of two locations to get to the vessels that supply the fibroids. We either enter the top of the leg in the femoral artery, or we enter the left wrist, which is the radial artery. And again, that's a kind of a topic for another day, but we can take either course. And some women really like the radial artery. Some women prefer the leg for various reasons. And either way, just like all the roads intersect, all the arteries intersect, so we can make our way to the fibroids and to the vessels that supply the fibroids by doing that.
And how are you making your way to the fibroid? What are you actually inserting?
We use this tiny tube called a catheter. And so depending on where we're coming from, we have to have various lengths of catheters and different designs and shape. But essentially the catheter, once it's within the artery, just like you and I can't sit here and feel our blood flow move, and it's not painful for our blood flow to move, it also isn't painful to have this little catheter directed around inside the artery. So this procedure is done under a little bit of sedation, moderate sedation. Doesn't incur the risks of general anesthesia. And so we just, a lot of women like to watch on the screen. Some people don't want to know anything that's going on. And so they just kind of, casually sleep during the procedure. If we need to arouse them, we can. And we take this little catheter and we make our way to the uterine artery. And within the uterine artery, we deliver this embolic, or these little grains of sand. They're on the micron scale, so really tiny. And they plug up the vessels that go to the fibroids. In general, we know.
Expand once they are at their location?
No, they're not. They're not designed to expand. There's various different types of embolic. They actually just lodge within the vessels and do, you know, an anatomic block of the vessel essentially. But the point is, rather than putting in some of the other devices that we have that are blockages to close off vessels that are more like coils or other things, these are meant to be on the tumoral level. So they're designed to be that small that they kind of match the size of the vessels that go to fibroids.
Okay, and how do you know if the procedure has been successful?
So we get some information once we deliver these, you know, this embolic to the fibroids. We can kind of generally see where the fibroids are, get a general idea of how the embolization went, but really the proof, you know, the proof is really at 3 months. And so women come back and they have a combination of things, the most important being their clinical symptomatology and whether it's resolved. But the second thing, when possible, and sometimes we get some pushback from insurance companies about this, but we obtain an MRI to look at the degree of treatment, you know, and the degree of what we call infarction or death of the fibroids. The reason why we do that is a couple of things. One being that we know if the fibroids are truly dead and completely dead, the likelihood of them coming back is much less than if a part of it is still alive. And that's true. The same phenomenon is true of myomectomy. If you get part of the fibroid and not the rest, we know that there's a likelihood that it's going to recur, particularly if a woman is far out from menopause. Mm-hmm. The hysterectomy, you know, anything that leaves a uterus behind, whether it's a embolization or a myomectomy, there's always a chance that a woman could develop new fibroids, but we give them some estimate of that based on their age, you know, when they come to see us. So it's a discussion that's had and sort of an expectation. If I treat someone who's 35 and I treat someone who's 50, it's a little bit of a different discussion.
All right, because one thing we didn't connect the dots is that usually fibroids regress on their own once a woman goes through menopause, so long as she's not taking any, you know, external source of estrogen.
That's absolutely right. And what I've learned in my practice, and it took some time to realize this, is that even when a woman goes into menopause, the symptoms of these fibroids can take a little time to regress, whereas kind of the same idea, essentially from an embolization, is what's taking place. We're not putting a woman into menopause, but we're taking away those symptoms just on a much quicker basis. You asked me, and I meant to say, how do we know that this worked? Well, I mentioned the 3-month mark, but in reality, most women with their very first cycle, about 50% of women actually have their symptoms gone or at a satisfied level. When we get to the 3-month mark, we see about 90% of women have a response. So, you know, it takes a little bit more time than a surgery, but the recovery is also obviously much, much less than with a surgery.
All right. So who's a candidate for this procedure?
Yeah, I would say most women are candidates for this procedure, but there's some nuances to that. And I think there's this feeling that with people who don't work collaboratively, that if they send us a patient to talk about uterine artery embolization or uterine fibroid embolization, that we're going to just say, you should get a uterine fibroid embolization and everybody should get a uterine fibroid embolization. But I will tell you that my clinic visits are lengthy because we spend a lot of time talking about what's the best option for that particular woman. And sometimes, occasionally, it is not a uterine fibroid embolization.
Okay, so tell us who's not a candidate for.
So who's not a candidate is a little bit of an easier discussion. I would say women who have fibroids in that endometrial cavity that we talked about. If we embolize those with no plan for a secondary procedure, they're at a higher risk of those fibroids becoming infected, and the uterus as a whole can become infected. The women can actually, I mean, that could truly lead to death in the worst case scenario. There have been or has been at least one death related to that. In, you know, not at our institution, but across, it's a well-known.
It's been reported.
It's been reported, yes, yeah. I was trying to stay away from too much academic talk, but it is something that we try to stay away from embolizing without a secondary plan. So sometimes a woman says, I absolutely don't want an abdominal surgery. I absolutely, you know, I already had a hysteroscopic myomectomy to take out this fibroid and it just didn't work. And so sometimes in that scenario, if they have one of those fibroids on the inside lining of the uterus and the endometrium, I'll say, let me talk to your gynecologist. Maybe what we'll do is embolize it. And within a week or two, they'll actually go in and resect the rest of it. So it helps reduce blood loss. It helps shrink the fibroid a little. So sometimes it helps with that hysteroscopic myomectomy and make it more successful.
And just to clarify, not all hysterectomies are abdominal. Yeah, there are women
Exactly.
who have vaginal hysterectomies.
Absolutely. And some hysterectomies, the woman goes home that exact same day, so I'm really impressed. And that's what's so interesting about working collaboratively is that if I didn't work that way, I would think hysterectomies were all bad, but because I've actually seen and been in hysterectomies where a woman has had a laparoscopic hysterectomy and gone home the same day, I know how successful and how great they can be. And I just think it's very woman dependent, and individual dependent. So we're talking about what woman is not a candidate. So there are fibroids that are more at risk, and those ones on the endometrial cavity are more at risk for us. Also, we tend to counsel women who want future pregnancy and future fertility that maybe fibroid embolization is not their best option. It's based on very little clinical evidence, but obviously they can't have a hysterectomy and get pregnant, so that's out of the question. They can have a myomectomy, and there is one decent, again, I'm trying not to get too academic here, but there is one decent randomized controlled trial that compares myomectomy and UAE that shows better fertility outcomes with myomectomy. So when a woman comes to me and says she definitely wants to get pregnant, and if she is a myomectomy candidate and it's likely to be successful, I will guide her in the direction of myomectomy. Occasionally, unfortunately, some women are in a rock and a hard place. They kind of still are thinking about future fertility, but they're not a candidate for a myomectomy. And so I have to have that very frank discussion with them that I may impact their fertility in some way. And, it's a sort of, do they want to move forward with some kind of treatment, or do they want to do nothing, or potentially do medications?
So what is kind of the guidance about the impact of uterine artery embolization on fertility? That you may be able to get pregnant, that don't count on it? And what do you tell women who don't want to get pregnant about contraception?
Yeah, so I think it absolutely is not a contraceptive method whatsoever. Women can definitely get pregnant after uterine artery embolization. We have lots of successful, normal, full-term pregnancies after uterine artery embolization. In fact, not too long ago, there was a study that showed that for women who actually desire pregnancy, the outcomes are pretty good for getting pregnant and carrying a normal delivery. However, there's no guarantee. And obviously, as you might imagine, this is a very difficult study to do when it involves women who desire future fertility. So the study the one that we all kind of reference, and why we say myomectomy may have slightly better outcomes, there was definitely some confounding factors in that. The general principle I have is if a woman can have a myomectomy and she's a good candidate for a myomectomy, I guide her in that direction. If a woman has life-threatening bleeding and is not a myomectomy candidate and obviously doesn't want a hysterectomy, because that would totally take away ability to have fertility, then we have to really counsel her towards an embolization, because in that scenario, it's not really elective at that point. If, however, she's willing to live with the symptoms and she's investigated all of her options and she wants future fertility, I may say do nothing or
medication or other options.
Exactly.
Is there any impact of uterine artery embolization on tubal pregnancies or ectopic pregnancies?
Yeah, that's a great question too. I do not know of an impact on that specifically, but I may be missing something in that. I don't know specifically about tubal or ectopic pregnancies. More of the concern is sort of carrying to a full delivery, and also about miscarriages. The miscarriage rate actually tends to be equivalent to a normal first trimester miscarriage rate. But in terms of whether a woman makes it full-term pregnancy is where we also have some concern based on the prior studies that have been done.
Okay. And so what are the most common questions women ask you about the procedure? Actually, I'm thinking now about the common questions people ask me. The next most common question I get is, how much does it cost?
Yeah. Is it covered by insurance is the big thing. And yes, it's absolutely covered by insurance. There's really, at this point, to my knowledge, I don't have any issues with insurance coverage, except with a few carriers, one of the issues that we have is that women are required to do certain testing that is not actually recommended by me or their gynecologist. So it doesn't actually follow any set of guidelines. For
Such
instance,
as,
what I mean by that is, so sometimes when a woman wants to have a uterine artery embolization, they'll say, well, the woman is 40, she needs an endometrial biopsy first. And if the woman doesn't have bleeding, intercycle bleeding, and she actually doesn't meet the ACOG guidelines or the, guidelines for an endometrial biopsy, why would we do an endometrial biopsy?
okay, so just so people understand, the reason they would be requesting an endometrial biopsy is to make sure that she doesn't have any evidence of endometrial cancer or hyperplasia, which would be an overgrowth of the lining of the womb, which is a precancerous condition. So
exactly, because
even though there's no evidence to support that, that's what they're saying. And I guess the rationale is because if somebody did have evidence of a precancerous condition or of a small early endometrial cancer, then you would, be much more heavily weighted towards having a hysterectomy.
Exactly.
I'm assuming. I don't work for an insurance company. I don't know how they make their.
No, that's absolutely right. A uterine artery embolization wouldn't be in that woman's best interest if she has another reason to have a hysterectomy.
Are there studies that look at women who've had uterine artery embolization who then go on to have a hysterectomy anyway?
There are. So the reintervention rate, at least that has been looked at for various different procedures, including myomectomy and uterine artery embolization. Most studies show that the reintervention rate for uterine artery embolization is higher than with myomectomy and lower than for ablation. So that's a subject that we haven't even covered.
We haven't even gotten there.
There are some other procedures that are non-surgical.
All right, you brought it up. So tell us what an ablation is.
Yeah, so an ablation is basically, what's the word? I can only think of cooking references. Ablation is a
fruit. We do it all here.
Right. So it's a way that essentially applies some type of energy, whether thermal, in this situation, thermal energy to a abnormality like a fibroid, or the lining of the endometrium in particular, to keep it from doing that very heavy shedding and heavy bleeding that occurs. Women have to be, this isn't something that I do, but women have to fall into very specific categories to be someone who's a candidate for that. And also, again, the reintervention rate is higher than for the other procedures that we've talked about today. It's interesting that the reintervention rate we talked about. One of the things that I always find really interesting is that women with pelvic pain who have a hysterectomy, that's still almost a quarter of women still have pelvic pain after the hysterectomy. So even the end-all be-all gold standard hysterectomy doesn't always solve the problems. And I'm not talking specific to fibroids there. I'm talking more just to pelvic pain in general. But it's interesting that there's kind of reintervention rates with everything, even the gold standard. With uterine artery embolization, there was an interesting study that was done that looked at women who had to have a second procedure. And these particular women went with a second uterine artery embolization, which is actually can be very successful. And some women, as we talked about, just as if they get treated younger in life, they have a long time to menopause, they may grow back fibroids. And so they may need a second embolization or another procedure. So these women who had a second embolization, at 5 years, they were asked, would you have done things differently knowing that you had to have 2 of these? And the vast majority were completely satisfied with the way they chose to go and would have repeated the same route, meaning getting 2 uterine artery embolizations. And they cited basically the minimally invasive nature, the fact that it was covered by insurance, the fact that they could get back to their normal lives pretty quickly, and that it was less painful than they presumed, than having recovered from a surgery.
So the other thing we didn't talk about that factors into the decision, we mentioned how age is a factor, and we mentioned the potential impact of menopause. But what we didn't talk about, and I'll take it back one step, is very commonly women use the terms for different types of hysterectomy incorrectly. Mm-hmm. So there's a term partial hysterectomy, complete hysterectomy. When we're talking about hysterectomy, we're only talking about the uterus. A lot of women use the term complete hysterectomy to mean that they had their uterus and their ovaries and their tubes removed. And there are many different reasons we might do that. In benign conditions, in uterine fibroids and benign fibroids, if a woman is 50, certainly if she has a history of ovarian cancer, her gynecologist most likely would recommend that, one of the advantages of doing a hysterectomy is we can also remove your ovaries. If the woman has already gone into menopause, we certainly would also take out the ovaries if we were doing a hysterectomy for any reason. Of course, an embolization doesn't impact that in any way. But I just do want to give a shout out to everybody who's using the term complete hysterectomy to mean their ovaries were also removed. And one of the frustrating things for me when I was seeing patients is many times women did not know if they had their ovaries removed as well.
Yes. I think that's probably less so, right now. But yes, I agree. Women are sometimes not well versed in what actually is happening. What's actually going to be removed or was removed. Most women now, it's a subject. It's actually one of the very common questions that I get asked in meetings with women when we touch on what are the alternatives to doing an embolization, which we always talk about surgical options, and we talk about hysterectomy. And it is a very common question for women to ask. So what does it mean if I just take out my uterus? What does it mean if they take out my uterus and my ovaries? And are they different? And it's a kind of a controversial topic because we know that taking out the ovaries and putting someone in premature menopause if they're younger is not ideal for their bodies. Can lead to premature heart disease, bone loss, all the things that are menopausal like side effects that we have to have when we get older, but we don't necessarily have to have when we're younger. So as you said, we try to leave the ovaries behind if we can. And when there's a lot of controversy about what if you do leave the ovaries behind, what kind of impacts are there really on a woman's health? And it's a hot topic. It's, there's something recently published in the journal called Menopause, and that a lot of my colleagues cite that talks about that some of those risks may be true even when the ovaries are left behind, probably to a lesser degree. I think it's too understudied and controversial to really come down hard on it. I do know that from the literature that a woman who has a hysterectomy, so the uterus comes out but the ovaries stay behind, they still have nearly a 2 times increased risk of ovarian failure despite leaving the ovaries behind. So that can put a woman into early menopause. Doesn't necessarily, they can have ovarian failure without being in true menopause, but it does there is some risk, and it does predispose them to other things. And one of the other
things, you can also have premature ovarian failure without having any procedures.
Exactly. And it's not to say that uterine artery embolization doesn't have some risk of that as well. It does, because there are some shared blood supply and anastomoses between the uterine arteries and the ovaries. So that's a discussion we actually have with women, particularly who are 50 or near 50, that we may precipitate it as well. It's pretty low risk, but it is possible.
Yeah, the other issue that, you talk about leaving organs behind, one of the other things which has gotten a great deal of discussion and controversy over the years is taking out the body of the uterus, but leaving the cervix. Because there's lots of discussion about how a hysterectomy affects a woman's sexual response afterwards. Now, I don't know of any connection between any complications or consequences of uterine artery embolization that affects a woman's sexuality or sexual response. Is that correct?
That's a great question. So I'm glad you asked. So actually, when we're doing the uterine artery embolization, we get in those uterine arteries like we talked about. We like to be at a certain point. We call it the horizontal segment of the uterine artery, because there, as you might recall, there are these, for women who've ever seen a picture of them, there's very tortuous kind of spiral arteries. And there's this segment called the horizontal segment, which we desire to be in. And the reason why is because we pass what's called the cervical vaginal branches. So the ones that go to the cervix and vagina. Again, low level evidence to suggest that there may be some impact on sexual dysfunction if we embolize those little cervical vaginal branches. So when possible, and what I like to say is sort of when the catheter goes nicely and it's not going to cause other issues and we can easily get beyond those branches, we do. It's not well studied, but there may be some impact on sexual function if we don't get beyond those. Most of the time, it's a very easy thing to do. And then sometimes we don't even see cervical vaginal branches, so complete non-issue in terms of embolization.
And obviously, if a woman is pursuing medical intervention because she's having pelvic pain, that's obviously having some impact on her sex life to begin with. And as you mentioned, many times, you know, a woman can have fibroids and have a hysterectomy and have them removed and still have pelvic pain. And then only retrospectively we say, oops, maybe that wasn't the cause.
Yeah, we try to figure that out beforehand.
Don't always know.
Yeah, similarly, women sometimes come in and they say, my fibroids are causing me to bleed, and they have this one fibroid on the outside of their uterus. And I'm like, that absolutely is not the cause of your bleeding. And it's actually adenomyosis or something else. And that's why an MRI before a woman's, you know, has this procedure, I think is a really good thing. That's another debate.
You brought up adenomyosis, so now explain what adenomyosis is.
Adenomyosis is essentially that lining of on the inside of the uterus, that endometrium, which we've talked about a couple of times, invaginates into the muscle of the uterus, and it causes symptoms that almost seem exactly like fibroids to some women. So they get heavy menstrual bleeding, prolonged periods, and dysmenorrhea or painful cycles. So it overlaps with fibroids tremendously. It even overlaps a little bit with endometriosis in terms of the pain. And so a lot of women don't know they even have it. And sometimes it's not even commented on or not well seen on ultrasound, which is what most women have first. And then when they go on to have an MRI, you know, we'll see this adenomyosis and these features of adenomyosis. It can be seen on ultrasound, don't get me wrong, but a lot of women, it's not picked up as well, and it's not as, you know, detailed as the MRI. So women often have both fibroids and adenomyosis, but there are times, like the description I gave you before, where a woman has a fibroid on the outside of her uterus, which is absolutely not causing her heavy menstrual bleeding. It may be causing bulk symptoms, but it's not causing her heavy menstrual bleeding. And I look at her MRI and say, actually, it's the adenomyosis. What's great is that uterine artery embolization works for adenomyosis too. So it's a treatment that we can utilize for both things, both conditions. That woman would not be a good candidate for a myomectomy because of her symptoms that she's complaining about is bleeding. They're not going to be able to do anything by taking out her fibroid. It's not going to change her bleeding. And a myomectomy does not work for adenomyosis because it's kind of this diffuse invagination of the myometrium or the muscle of the uterus, and you can't go in and really resect that.
So in the intro, I talked about how common and pervasive fibroids are. However, there are lots of women who have heavy menstrual bleeding during perimenopause who do not have fibroids, or who, as you said, may have, you know, one small isolated fibroid. But I do want to assure women that if you're having, first of all, if you're having heavy menstrual periods that are causing you to change your tampon or pad, you know, every hour, you need to see your gynecologist about that. There are lots of things that can cause that, and there are lots of things we can do to intervene. But in many women, and I know I was in this situation myself, I do not have fibroids, or at least that I know of, but I did have crime scene periods when I was in perimenopause just because of, you know, hormonal fluctuations. So that eventually does go away. I do hear a lot of women who have very heavy menstrual bleeding who don't want to go to their gynecologist and don't want to have it taken care of because they think erroneously that their only option is a hysterectomy. And fun fact, I had shared with you that I did my senior thesis in college as an undergrad on the elective hysterectomy unnecessary surgery debate. And without disclosing way too much info, that was in 1980. So this debate has really been going on. But the good news is in 1980, when I did my senior thesis on that topic, there were 800,000 hysterectomies performed a year.
Yeah.
And now that number is down to 200,000. So even though our population has greatly increased since then, and also the demographic of our population has greatly changed since then. But there are still women who think their only option is dealing with it, biting the bullet, or having a hysterectomy. So I think you've given...
That's exactly what was so impactful to me when I saw these women in clinic and they underwent an embolization and came back and had success, was that they were so thrilled with the fact that they didn't have to have a hysterectomy. But there is some truth to why they feel that way. The number one indication in the United States for hysterectomy is fibroids. Mm-hmm. And of the women who get a hysterectomy for non-cancerous conditions, 1 in 5, when you look at the data, has really no evidence for having had that a hysterectomy. So it is a little bit of a
No evidence for having had to have?
For having had to have the hysterectomy. And about 40% of those women who have a hysterectomy specifically for non-cancerous conditions never had another treatment option. Not that they didn't have some presented, we don't know that, but never underwent any other treatment or tried another treatment before having a surgical, fix, a complete hysterectomy. Or again, now I'm using the words wrong. So some type of hysterectomy. So you can see why a woman might feel that way particularly in certain potentially areas of the country, or, because of what their parents or their mom might have experienced or their aunt might have experienced. And so you're right, we're heading in the right direction. But you can see where that thought process may have been instilled.
Well, and a lot of women who are entering their 50s now and talking to their gynecologists just about menopause and what to expect in their menopausal experience don't really have a family history that they can draw upon because their mothers had a hysterectomy.
Yes.
So what happens to women's periods after they have embolization? Is there any effect?
Yes.
Aside from the heaviness of the bleeding from the fibroids.
Yeah. So as you said, the heaviness, most and greater than 90% of women, the heaviness of those periods go away. Some women get an amenorrhea completely, but those are really the women who are probably close to that on their own. And we kind of give them that extra push. So those women that are closer to menopausal age. Most women have a period similar to what they had before in the sense of how, at the timing of it or those kinds of characteristics, but they lack the severe heaviness. Some women even come back and they're like, they're just so shocked, and they actually don't think they've had a cycle because they say, well, I had this couple of days of bleeding, but I haven't yet had my period. And I'm like, no, that
is your period.
That is your period. So yeah, it can be a pretty profound change. And
what I used to say is now you're having periods, not exclamation points.
Yeah, I love your description, crime scene bleeding, because these women, I'm telling you, there's all these things. There's the White Dress Project. There's all these different things, and they're around for a reason. I have women all the time that come to my clinic that say, by the time I drive from my house, the 10 minutes to work, I'm afraid to get out of the car. I just changed my, super plus tampon and pad, my sometimes diaper essentially, and truly, and I get to work and I'm afraid to stand up because they have this phenomenon of flooding. And so, I had a woman just recently who came to me who said, there's a day where my work, everybody wears white. We do this thing once a month or something where we all wear white. Well, this time that happened to correspond with when she was on her cycle. And she actually had to go to her superior and say, I cannot wear white on that day. It is absolutely out of the question, or I'm just going to accept that I'm going to bleed through it and I'm going to wear like a black coat on top of it or something. And that's the reality that these women are dealing with. It's like unbelievable, amounts of bleeding.
Well, I think most women have had an experience at some point where there was, an embarrassing story. I know I had a story. I had just graduated from college and I was at a pool in this like awesome white bathing suit sitting on a white towel. And I stood up, eventually felt like I had to go to the bathroom and the towel was red and I was red. And
now your face is red. And
no, I just very casually wrapped the towel around my waist and just pretended like nothing was wrong.
Yeah.
So that often happens.
You're right. Everybody has had kind of that kind of experience. And I know you're, one of the things from watching your other podcasts, I know you're happy to have people share personal experiences. And I think it's the reality of what we're dealing with as women. I personally don't have fibroids, at least to my knowledge. But yeah, I mean, I've had an experience like that where it was driven by medication, but I had what we call missed abortion, meaning a baby that stopped growing early on, a miscarriage, just like a lot of women have, but and products didn't actually pass on their own. So you can have a DNC, or you can take medication that expels everything. It's a very sad topic, and a lot of women deal with this. I had that between my first two pregnancies, between my daughter and my son. And when you take that medication, you experience this, the medication causes that intentionally. It sheds that lining in a severe way, and you're passing golf ball sized clots. And it's crime scene like, as you mentioned, and emotional for other reasons. But the point is, that was my only real experience where I got to sort of have that mimic of what these women feel like. They would explain this to me, and I don't think I truly understood until I had that. And you literally can't move. You can't get up. You can't go anywhere. You can't do anything. And these, in this day and age, women are doing everything, right? So, they're sometimes the breadwinners. There's, they're with their children. They're so active. Sometimes we call ourselves the chief of everything, right? The CEO. But they are busy, and they can't, miss work is a big deal, and miss time with their children and all those kinds of things. And it's limiting. It's life altering. And so I think I finally grasped what exactly they meant in my clinic. And I appreciate that I've had that experience, because I can fully understand sort of just a tiny snapshot of what they experience on a monthly basis.
And I think, we certainly, in medicine, we treat a lot of things that we have never had and hopefully never will have. And I don't think you have to have had an experience to be able to empathize or to be able to treat your patient compassionately. And sometimes it helps to not have had a connection, especially when we're talking about cancer and, other things. However, that having been said, there's certain shared experiences that we have had as women. Certainly having had a miscarriage is one that's a very common experience shared by, 1 in 8 women. Well, actually, technically, that's not correct. 1 in 8 pregnancies. But that's, when you go through something like that, it changes your whole perspective. Now, many times when we have that, we then laugh about it, not a miscarriage, obviously, but certainly we laugh, now that I'm 40 years away from that embarrassing, bleeding on the towel experience, now I can laugh about it.
Sure.
I wasn't laughing about it then.
No, but you're right. There are certain things that you definitely don't have to have had the experience personally to relate. I think there are some where there's added value. I think this is probably one of them, to fully understand, because it's a benign condition and it's an elective procedure. And a lot of people look at it like, do we really even need to be talking about this? But we do need to be talking about it.
Because there's just tremendous a knowledge gap between the patients who might benefit from this procedure and knowing how to access it. Because if they go to first of all, they may not go to their gynecologist in the first place because they may not want to deal with it. Or they may think that their only option is hysterectomy. The other thing that's changed dramatically since 1980, when I did my thesis on this topic, are the range of treatment options. Certainly even medications that can be useful in certain circumstances.
Right.
So, that's also huge advances. And this is one of the reasons I always take the opportunity to remind people about the importance of their annual exam with their gynecologist and their internist, or the other. Because medicine changes, not just you change, but our medically available therapies and what we have to offer can change. But I think also a lot of women who experience really heavy bleeding don't associate that with any other symptoms. And this I always find staggering, that we haven't really educated people to the point that we tell them, why is it a problem that you have heavy bleeding? So 30% or 25 to 30% of women who are still menstruating are anemic because of heavy periods. And anemic just means that your blood count is so low. I know you know this. I'm telling to our listeners. Women get fatigue as a result of anemia, headaches as a result of anemia, increased risk of other infections or viruses or susceptibility to other illnesses. So it's not, even though fibroids we call benign or generally benign because they're not cancer, that doesn't mean that they don't have symptoms that could really affect somebody's quality of life.
We see, some scenarios that are truly life-threatening bleeding, and particularly probably the one that I see not uncommonly is women who get on some type of blood thinner, and then their fibroids become sort of unroofed in a sense, or they become more aware of the amount of bleeding that they have, and so they kind of had previously maybe undersold how severe their bleeding was because they're so used to it, and then they get on a blood thinner, and with the way sort of our other medical conditions that are more prevalent now, like getting a clot in the leg for various reasons. So DVT with, and pulmonary embolus. Those things are not uncommon, and various other conditions can cause those clots to form. And so women get on blood thinner for whatever reason, that being one of the most common, and they come in just bleeding severely from their fibroids, which were previously manageable to some degree, and they may have had some degree of anemia, but they get on these blood thinners, and it can be really, really traumatic. And then there's the whole set of population who won't accept blood products for various reasons, one being religion, and that's another topic that is important. And we have a bloodless medicine institute where we are, and it sometimes is the case that even when a woman desires a hysterectomy for the treatment of her fibroids or some other pelvic condition, sometimes we'll actually embolize those women beforehand to try to decrease their risk of needing or having such severe blood loss during the procedure, leading to even more severe anemia, because they don't accept blood products as a method of treatment. And so
the other point I want to make, back to your point about blood thinners, is whenever we talk about blood thinners, it occurred to me that we forget to mention to people that aspirin and many non-steroidal anti-inflammatory drugs like Motrin, ibuprofen, Advil, etc., are blood thinners.
Yeah.
And people don't generally understand, when we have over 100,000 people a year having complications of GI bleeds from these products, people don't understand that if you're having any kind of bleeding issue, you might want to cut back on the amount of aspirin or aspirin related products or non-steroidal anti-inflammatory drugs that you're taking for your arthritis or your back pain or your headaches or any of those other kinds of conditions. And many times physicians will ask patients if they're taking blood thinners, but they won't say, are you taking aspirin? Or even because your father had a heart attack and you think, or you've been advised to take a daily baby aspirin to prevent, your risk of heart disease. So all of those things, just show what we always talk about is, that whole knee bone is connected to the hip bone thing. And all of these things are interrelated. I could talk to you about this all day, but just to wrap up, what's the one main thing you want women to know who've heard this conversation?
Yeah. I think, to know, you really touched on this, that medicine has changed. There are a lot of options, and that really they deserve to know their options, and they need to hear about them from the specialist that does those things. So go to your gynecologist, absolutely. Ask for the alternatives. And I hate the word alternative in this scenario, but ask for the other options. And so you can make a decision along with your healthcare providers. Be involved, what I like to call shared decision making, so you can determine what's best for you, along with the recommendations made by that collaborative experience between the gynecologist and an interventional radiologist, or whatever specialty it is that you're seeking potential options for treatment. Know that there are other options, and know that you can hear about them in detail from the specialist, and that it's okay to ask. Men do it. They ask, I promise. It's okay to ask and look for other things. Men do it
when they go to the doctor.
Yes, exactly.
Don't always go to the doctor.
Yeah, exactly.
I know why you balk at the word alternatives. It has a connotation of, alternative medicine, and am I choosing one from column A or two from column B? Medicine doesn't always work that way. So I think a better word for alternatives, and certainly options is a great word, but choices. Choices is a great word because it tells you that you can find out what the different options are, but at the end of the day, the choice of which option is up to you in consultation, with the physicians you've consulted. And not doing anything is also a choice.
Exactly.
And I think people often forget that, when they're worried about the consequences or complications of medical intervention, whether it's minimally invasive or whether it's surgical, they forget to remember that, or they don't remember that not doing something also has consequences or potential consequences.
Yes.
So anyway, with that, where can people find you, and where can they find more information about this?
Yeah, so there's a lot of ways to find an interventional radiologist. One specific to fibroids, you can go to their sites like askforufe.com, and you can actually find somebody, a local provider in your area. I think as a whole, we're not a huge community of interventional radiologists, although getting bigger. And you could really reach out to anybody and find a connection some way. So, for instance, if you can't find somebody in your area, you could reach out to me, and I could help you, facilitate that. The Society of Interventional Radiology is a place that they work in conjunction with the Ask for UFI site, for instance. But if you're looking, whether it's UFI or any other sort of minimally invasive procedure that an interventional radiologist does, I think this is the SIR, or Society of Interventional Radiology, is a good place that you can always contact someone and they can find you someone in your general area.
Yeah, and hopefully you have a relationship with your primary care physician, your gynecologist, who can give you a referral. And very increasingly, I have to say, I'm pretty impressed with insurance company websites that have Find a Doctor, where you can
true too.
Put into the website what the specialty is of the person that you're looking for and find somebody who takes your insurance. And of course, that's an actual, reality of, the way our healthcare delivery system is structured these days. And that's a whole nother topic.
Yes.
So on that, thank you so much for joining us today. I think you've really educated a lot of people, including me, and I really appreciate it.
Thank you as well. It was actually a ton of fun and very relaxing. And
Great. See, it's not scary in the ladies' room.
It's not scary in the ladies' room, but nothing in the ladies' room stays in the ladies' room. So just remember that.
Take care.
That's all we have time for today. But let's keep the conversation going on Twitter or Facebook at Dr. Donica. And please join us next week for another episode of In the Ladies' Room with Dr. Donica. Real conversations with real women about really intimate topics.